See, I'd never lose an opportunity to get a chance to speak, so I had to remind him. Uh, Thank you so much, Dr. Vishal Rao, to join us. He was supposed to be with us today, but unfortunately he had an important case that he couldn't have avoided. So last minute he had to choose to be with us only virtually. Dr. Anand, Dr. Bansal, thank you so much for joining us. You know, when we talk about cancers, and one of the things that is coming out very clearly during the conversation that we've been seeing since morning, or hearing since morning, that all cancers cannot be treated in the same way. You know, but it entirely depends on when the cancer is getting detected. The treatment, the prognosis is dependent on that. How can the head and neck cancer be detected early, and how is research in this area of diagnosis advancing so that we are able to detect the cancer in time and make a positive contribution to saving lives? Dr. Anand.
Yeah, thank you very much for inviting me here. So I think in the previous panel discussion also, a lot of emphasis is on number one, prevention, and if prevention is not succeeding in some of the population, then early detection. And why we should do early detection is that it can change the treatment drastically, I would say. So one thing overall which will happen is with early detection is we will detect the tumor in stage 1 or maybe early stage 2, where we can conserve the organ. So I think the biggest problem patient faces is as soon as cancer is detected, he is very scared of losing the organ, either to surgery or to very extensive chemo, radiation, and surgery plus radiation, because as the tumor advances, the treatment also becomes more complicated. So as an example, we can say that if patient is detected stage 1, voice box cancer, or the hypopharynx we call in the throat, stage 1 we can just cure with simple radiation therapy without losing the organ. So his voice will be conserved. So when a patient of head and neck cancer gets treated, his main concerns are whether he can have voice, he can talk normally in the gathering like this, or also whether he can have social eating. So many people who have been detected late and received multiple lines of treatment, they are shy of eating in public because they have dry mouth, because of radiation or surgery, they can't swallow, they go in one corner of the room and try to eat over there. So I think that is a very big stigma. And that stigma we can reduce if we detect early a single modality of treatment, and the resultant loss of activity or the loss of function of the organ is minimized. And therefore, the main emphasis is on quality of life. Early detection means we can give cure with good quality of life.
Thank you, Dr. Anand. Dr. Vishal Rao, my next question is to you. What is the importance of personalized and precision medicine for the area of head and neck oncology, and what is the progress that we have seen? How has the personalized medicine evolved to where it is today, and where are we headed?
So I think one of the most interesting things in the last five decades that we've seen in head and neck cancer overall has been the discussion on precision and personalized medicine. And this is catching up more in the West. You know, there was an interesting article in Lancet in November 2017 which talked about the cancer moonshot, which actually highlighted on precision oncology and personalized oncology as one of the futures of oncology focus. But still, there was also a lot of discussion on the cancer ground shot, on what is it that we have to achieve on ground. Now at this juncture, while all of us are pursuing towards personalized and precision medicine, it is a very apt and a a very reasonable, I would say, endeavor, because 50% of our patients tend to fail, and most of them come in advanced stage, local reason. And unfortunately, we have but the same formula of again doing surgery, chemotherapy, or doing any one of them in combination, without understanding specifics of the genetic makeup of the tumor, without understanding the biological nature of the tumor. So where is personalized and precision oncology heading today? I think there are a lot of data gathered all around globally in various organs that the subset that it represents. For example, if it's a tongue cancer, and if you study the entire core exome of this particular tumor, you will find that biologically it will be behaving more like a renal tumor or like a leukemia. So there is a lot of signatures that today are coming out to say that what you assumed as a site-specific approach could genomically be having a completely different signature. So there's a lot of movement towards saying that maybe these signatures are harbingers of telling that they are radio resistant, they are chemo resistant. So why should you repeat the same thing that you know in results will give you 50% failure? Similarly, immunology has taken a big leapfrog to say, we had a recent paper of ours published on something called ITNM staging, where I stands for immune system, T stands for T cells, N stands for neutrophils, and M stands for macrophages. Rather than going towards the same old size approach, so we did this study with the group from Mayo to actually look at circulating tumor cells and looking at staging system, where we found that a person who attacked a stage 4 cancer with a bad prognosis actually had more circulating tumor cell clusters. This is one of the papers that was published by a group in Nature. And patients who were actually in stage 1, where we actually assured them excellent prognosis, had aggressive circulating tumor cell clusters, showing that these are possible patients who are going to prognostically behave much badly. So I think it is time to rethink on the approach of only stage, which is size-based, and move towards understanding personalized medicine and moving towards, again, precision medicine, targeting precision genes, talking about genomics, talking about immunology, and also talking about microbiomics. Microbiomics has come out in a very, very long way, with gut microbiome and oral microbiome both contributing significantly to understanding the immune system today. So even talks going on about that these microbiomes could also be harping on oncobiome. So I think this is where we will be heading towards in precision and personalized medicine in the future. Thank you.
Thank you, Dr. Rao. Dr. Bansal, since we're talking of genomics, I mean, that's how we'll read towards precision medicine. The need for genomics and the need for personalized medicine is because we've understood that each body is different, and the same medicine may not be working for everyone. Do we see people taking these genomic tests voluntarily? Is it increasing? And if it is not, what could be the cause and what needs to happen?
That's a very, very important question. So if we talk about precision oncology and genetic testing per se in head and neck cancers, I would say we have not been able to achieve much, or not is being done currently. But if we talk about lung cancer landscape, like just to give an example, so we are able to do certain genetic testing by the name of, say, next generation sequencing. And we see that suppose if a patient has, just to name, I don't want to load you all with medical jargon, but just to explain, there's something which is known as EGFR mutation. So if that is detected, then the patient may not need injectable chemotherapy. We are able to give an oral pill. So similarly, like ALK4 mutation, we are able to give an oral pill for lung cancers, and this is happening in many other domains. But in head and neck cancer, the work that is going on is, one is, there are 2-3 ways of looking at it. One is that you check the particular gene which is responsible for tumor in that particular patient. So that is what is done by next generation sequencing. But unfortunately, we don't have much till available in India. Number 2 is that you do something at, Dr. Rao also mentioned, at a DNA level, circulating DNA level, where you can see whether the patient who has been cured of cancer, if the circulating tumor cells in the DNA are being picked up, then patient might have tumor recurrence. Then microbiomes, you check for the saliva of because there are some microorganisms which are in your saliva, and depending on that, you check the microbiome of your saliva and you do certain tests. And then you can do radiomics, where you can see why the tumor resistance is developing, or you can see which area to focus on with radiation or which area to focus on with surgery. These are some of the emerging things which are happening in the head and neck domain. But regarding why don't people go for checkups, number one, head and neck cancers, they are not somehow more genetically transmitted diseases. There are very few cases where genes are responsible, unlike breast cancer or ovarian cancer, or breast cancer or prostate cancer, which run in families. Head and neck cancer somehow doesn't run in families. It's more because of tobacco and alcohol or HPV. So coming to HPV, like we have been able to detect that certain head and neck cancers are HPV driven. So somehow, and we have seen that these oropharyngeal cancers, they behave better as compared to the patients where disease is not HPV driven. So for oropharyngeal cancers, mean cancers of the base of the tongue, we have started doing HPV routinely to personalize their treatment. Coming to why people don't go for checkups, like people for other cancers also, say for breast cancer, one is, unfortunately, we don't know that these tests don't predict. They just predict that you are at risk of cancer, but they don't predict how soon the cancer will develop. Say for breast cancer, they will not tell whether the tumor will come in the right breast or it will come in the left breast. After how many years the cancer will develop, will the patient have a cancer in the ovary, in the left ovary or the right ovary, so which breast to get removed. Prophylactic oophorectomy is still being done. And second is stigma. It was also spoken about in one of the earlier sessions, that if you know that you are at risk, but you don't know when the cancer will develop, patient आधा वैसे ही मर जाएगा. They will stop living. And social stigma, people will not marry of their children in those families. You will not get jobs. And sometimes we know which particular gene is responsible, but we don't have enough medicines in the market which are available in India, or if they are available, their cost is exorbitantly high, which a person can't afford. So these are some of the limitations which are not helping us do much of genomic tests, specifically in head and neck domain and in other areas as well.
Got it. Thank you, Dr. Bansal. Dr. Anand, there are deformities caused as a part of the treatment of head and neck cancer. Is the technology evolving to a stage where we are minimizing the chance of deformities? Are we making progress in that stage so that we can minimize it to some extent?
Yeah, I would say that is the most looked after aspect of cancer treatment which has happened in the last about 1.5 decades. So technology has helped us a lot in terms of reducing the morbidity of the treatment. For example, in surgery, there are minimally invasive surgery, robotic surgery, all that is coming. And also, there are the reconstruction techniques which a surgeon uses while removing a tumor, they are also improving. In radiation also, there is a remarkable improvement. In good old days, we used to have radiation therapy, linear accelerators, of course, we had, but we didn't have the capability to treat a tumor and save very important glands. We have parotid glands and salivary glands. Now, those used to get treated to a high dose, and patient used to develop permanent dryness of mouth. Second thing which used to happen was person used to develop problem in swallowing. So that's what I mentioned. So that was the problem with our older techniques. Now we have very modern techniques like IMRT, intensity modulated radiotherapy, or image guided radiotherapy. So these techniques can selectively protect salivary glands. We can protect swallowing muscles and yet give a curative dose of radiation. So this is I have seen in my own lifetime. We started IMRT in 2002 I was in Rajiv Gandhi that time, and now it is 22. So in the last 10, 15 years, or rather 20 years, there's a remarkable improvement. Now when we see patients coming to us in OPD, they have near normal swallowing, near normal speech, and this has been a tremendous improvement. I would say this is one of the most important development which has happened in radiation oncology, where we have improved cure rates and reduced side effects associated with treatment. So people should not be afraid going to for treatment, looking that the deformity will be very high. And so we sit with surgeons and devise the most suitable treatment for that patient. So it is a personalized medicine again. We have to sit with surgeon and medical oncologists to find out what is the best possible treatment in terms of cure, and also in terms of quality of life, which includes swallowing, speech, social gathering, his movement, his appearance. He should not be afraid of himself looking at the mirror. So I think that is very, very important aspect which you have asked. And there's a tremendous improvement and tremendous, I would say, kind of improvement which has happened, and it has led to improved quality of life, yes.
Thank you, Dr. Anand. In the interest of time, this is my last question. Dr. Rao, what is the role of robotics, since it is now powered with 3D visualizations in head and neck surgeries? What's the impact that we can see in the coming times?
Harbinder, I think one of the most interesting things in the last couple of decades that has happened is machines entering into our operating rooms. Now, if you look at it from a perspective of the true technology, it's a master-slave system. There are 4 stages in AI. We call them the narrowband intelligence, which is what is Alexa and Siri. Then we have the limited memory AI, which is what Elon Musk is talking about in driverless car. And I remember pre-pandemic, one of the meetings that I had at Tata Institute, when we were talking, I was telling that what Stephen Hawking was worried about was about self-aware AI and about theory of mind in AI. Now, just recently in July, somebody from Google has been put on a gardening leave because he's cracked the self-aware AI. So I think we are at a very rapidly evolving phase in artificial intelligence and robotics, where these machines are learning. They are here to accelerate, accentuate, and assist our human hands in healing. Specifically in surgery, what I'm seeing is, for example, when we started off about 6-7 years back, our robotic surgery program, head and neck was a very small aspect. We primarily ran robotics with urology, then GI. Third was head and neck, and then gynecology. Today, in my hospital, I have one robot dedicated to head and neck. So the volumes have increased. If you ask me, like sir said, the cosmetic outcomes, the functional outcomes have been making a great difference for thyroid cancers. And now we are using it for mandibulectomies, neck dissections, and a lot of our patients who have early cancers with small tongue cancer, but we have to treat the neck where you have to give them an ugly scar. We are avoiding that. So we are not pushing for robotic, but we are telling patients that there are informed choices. And even from a cost perspective, it's not been a huge impact to patients. We did our own cost analysis, which we are publishing soon on cost-to-cost comparison between open versus robotics. So what I see is a great potential for robotics in the future. It has got great imaging technology, and for sake of simplicity to tell you, we surgeons have small eyes and big hands, and a robot has big eyes and small hands. So it's able to go to areas which we traditionally wouldn't imagine we could access so easily. And it is able to do it with such great clarity and ease. So in one hand, I have a forceps and a bipolar cautery. On the other hand, I have a scissor and a unipolar cautery. Totally, like I have 4 instruments and I can move them 360 degrees all through it. And I can reach complex areas with wonderful visualization. So definitely an addictive tool. It has certain limitations right now, not to be overused, but great potential for the future. And I tell the younger generations, it's time that they adopt this, learn more amount of these technologies, because they are here to stay.
Thank you, Dr. Rao. I wish I had more time, because it's very rarely that you could get Dr. Rao, Dr. Anand, and Dr. Bansal together on the stage. But I'm glad that you could take time out to share information on the technological development, especially in the area of head and neck. And it's encouraging to know that the robotics is making a difference to be able to, like Dr. Rao said, to reach those areas which otherwise were not possible to reach earlier, and to be able to create better outcomes and help people live longer and better with minimal deformities. Thank you so much for joining us, doctors.
Thank you.